Hello, everyone, and welcome to the NETEC webinar focused on introducing the Joint Commission standards for infection control with specific emphasis on the high consequence infectious disease preparedness elements. My name is Angie Basha, and I serve as the Director of Readiness Consultations and Metrics Development for NETEC and the Director for Biopreparedness and Special Pathogens Programs for the Region 7 Regional Emerging Special Pathogens Treatment Center. I'm excited to be co-moderating today's webinar with my colleague, Ms. Carolyn Pearson, who serves as Program Director for the Mountain Plains Regional Disaster Health Response System and the Biocontainment Unit at Denver Health. Before we dive into the webinar content with our esteemed panelists, I'm going to provide a brief overview on the history and the evolution of NETEC and the National Special Pathogen System. Following the 2014 to 2016 Ebola outbreak, ASPR, the Administration for Strategic Preparedness and Response, funded NETEC and the Regional Emerging Special Pathogen Treatment Centers to create a national tiered structure. However, as with most outbreaks and public health response efforts, the funding has waxed and waned over the last 10 years, and in the last 4 years, the tiered structure has begun to degrade. As we responded to the pandemic, it was evident that the need to reestablish a national structure to respond to emerging and re-emerging special pathogen threats was critical. In 2022, ASPR funded NETEC to reinvigorate this national special pathogen structure. NETEC serves as the coordinating body for the National Special Pathogen System as directed by Congress. Initial work has been focused on strengthening the regional relationships across the network and further building out the system of care beyond the 13 regionally emerging special pathogen treatment centers. Our mission is to set the gold standard for special pathogen preparedness and response across health systems, with goals of driving best practices, closing knowledge gaps, and developing innovative resources, which we achieve through our 4 core activities. These are focused on consultation and assessment for healthcare facilities and EMS agencies to prepare their programs for special pathogen response events, education and training, where we develop and offer resources, educational materials, and training for healthcare professionals. Our Special Pathogens Research Network, which focuses on developing the infrastructure to provide researchers with training, tools, and resources to quickly and effectively respond to research needs during a special pathogen emergency. And our international partnerships and programs, which helps us focus on the development and expansion of relationships across global high-level isolation unit partners. In synergy with a network, the mission of the NSPS is to provide a coordinated and standardized healthcare network of high-quality patient and community-centered care for patients suspected of or infected by a special pathogen, with the ultimate goal of protecting the healthcare workforce. Our ability to achieve this mission will help us actualize the vision to save lives through sustained and standardized special pathogen systems of care that provide equitable access for all U.S. citizens. As NSPS work continues, our aspirational success measures will demonstrate the achievements of the system, including the ability to mobilize a network within 2 hours of a suspected special pathogen incident, having access to high-quality special pathogen care for 100% of the U.S. population, and achieving 0 preventable deaths after a special pathogen infection. These missions are achieved through the collaborative efforts of the 13 Regional Emerging Special Pathogen Treatment Centers, or as you'll hear them called, RESPECTs. These are located across the country. More than 100 industry leaders representing healthcare specialties, infectious disease clinicians, emergency medical service leaders, all share their expertise across NETEC's 15 national work groups and 9 task forces. There are currently treatment centers in all 10 of the HHS regions, with co-located regional treatment centers established in HHS regions 3, 4, and 5. If you're not familiar or acquainted with your regional emerging special pathogen treatment center, we encourage you to reach out to them, as they are the highest tier of care facilities within the special pathogen system and can serve as a resource for your organization. You can find their contact information on our NETEC website, which can help you engage with your regional treatment center. In addition to the regional treatment centers, which are designated as the level 1 facilities in the infographic you see on your screen, these facilities serve as resource hubs for their regions, providing highly specialized care to patients suspected or confirmed to have a special pathogen. In addition, there are 3 other tiers of facilities, level 2 facilities, previously known as state-designated treatment centers, who really serve to expand the capacity of the system to deliver specialized care for clusters of patients for the duration of their illness. The next level will be the level 3 or assessment centers, which are facilities that will be widely accessible care delivery facilities with the goals of being able to conduct basic laboratory testing, identify, stabilize, and coordinate rapid patient transfer to minimize impact to normal operations. And finally, level 4, which is essentially every other healthcare facility. So all of us are included in this tier. The expectation for these facilities is to be able to quickly identify, isolate, inform, and initiate stabilizing care for any individual suspected to have a special pathogen infection. While organizations will self-identify or opt in to serve as levels 1, 2, or 3, all healthcare setting facilities where patient may present for care are part of the National Special Pathogen System. The capabilities listed here for level 4 are aligned with the infection control standards released by the Joint Commission that focus on high consequence infectious diseases, which we will be highlighting today. The webinar today will discuss the Joint Commission pre-publication standards for the infection control requirements that go live July 1st of 2024, with an emphasis on those that refer to high consequence infectious disease standards. Our webinar will not discuss other accrediting bodies, which includes the DNV Healthcare, the Accreditation Commission for Healthcare, or ACHC, or the Center for the Improvement of Healthcare Quality, or CIHQ. If you do have specific questions about these entities or their approaches to high consequence infectious diseases, we've included the link to their websites to contact them for more information. And now I'd like to welcome Dr. Natalia Rosenberg, who will be overviewing the pre-publication Joint Commission infection control requirements and compliance with the standards of IC 07.01.01, Preparedness for High Consequence Infectious Diseases. Dr. Rosenberg is a project director in the Department of Standards and Survey Methods at the Joint Commission. And Ms. Kelly Getman, who will be highlighting implementation strategies and a discussion of the changes for the elements of performance within the infection control standards. Kelly has over 25 years of nursing experience and works within the Department of Patient Safety and Quality at Denver Health Hospital Authority. And now I will turn it over to Dr. Rosenberg, who, as we noted, is the project director in the development of standards and survey methods at the Joint Commission. Within this role, she is responsible for developing and maintaining accreditation requirements for hospital and non-hospital programs. She has led a variety of projects, including pain management standards updates in 2018 and 19, the NPSG review in 2019, the resuscitation from 2020 to 2022. She is currently leading the Infection Control Chapter Rewrite project for all accreditation programs. Dr. Rosenberg, over to you.
Thank you, Angie, and good afternoon, everyone. It is my pleasure to be here today to speak to your group. What I'm going to cover in my part of the presentation is to give a brief high-level overview of the key changes in the Joint Commission infection control requirements for hospitals and critical access hospitals. The revised standards are currently in pre-publication and will become effective in July of this year. And then I'll spend some time on the new standard IC 07.01.01 on preparedness for high consequence infectious diseases or special pathogens. And I will go over the key points that organizations need to understand to successfully meet compliance. This is the mandatory disclaimer slide for the Joint Commission. I won't read it, but if you plan to distribute the slides, please read this content regarding that. The infection control accreditation standards for hospitals and critical access hospitals went through revisions recently. The Infection Control Chapter Rewrite Initiative, as we call it, begins with hospitals, but will eventually include all programs that the Joint Commission accredits. The Joint Commission periodically reviews its requirements in order to retire the ones that have become dated. And lately, we have accelerated the pace of such reviews and put a more intense focus on simplifying requirements, removing requirements that do not add value to accreditation surveys, and leaving those that are key to quality and safety and most meaningful for evaluations of hospitals. We align standards more closely to the mandatory components that organizations must follow, such as law and regulation, and the Center for Medicare and Medicaid Conditions of Participation. You will notice that the rewrite largely eliminated the differences in the language that existed between our infection control standards and the CMS Conditions of Participation. So what will the new infection control chapter look like? The standards in the chapter will become more high level, condensed, and reorganized. In the current structure of the infection control chapter, of accreditation standards for hospitals. There are 12 standards and 51 elements of performance. In the future state, beginning in July, the chapter will have 4 standards and 14 elements of performance. To help organizations see how the key concepts have migrated from the old structure to the new structure, we provided a reference guide that is posted on our website along with the pre-publication standards. Please access this document and examine those details. You will also notice that the numbering has changed for the standards, and that is both for hospitals and critical access hospitals. The basic skeleton of the infection control standards is shown here. There are 4 standards. The standard 040101 addresses the structure of the infection prevention and control program, and it will include the requirements for the program leader responsibilities, and the program policies and procedures. The standard 050101 concerns the accountabilities of the hospital's governing body and the role it plays in supporting the operations of the infection prevention and control program and its performance. IC 060101 is on implementation of the various infection control activities. It will include assessment of risk, routine activities, requirements for the management of outbreaks, and processes to protect staff. So many of the concepts that I've just mentioned are not new to any of you, but they're just reorganized differently in the chapter. The standard 070101, the final standard in the chapter, requires processes to support preparedness for high consequence infectious diseases or special pathogens. And this is the only new standard that was introduced in the infection control rewrite. If the standards are concise and at a high level, you may ask, where are the details on the very many infection control practices that hospitals must adhere to and are surveyed to? Going forward, those details will be provided in the Infection Prevention and Control Program Assessment Tool. The tool lists infection control practices such as hand hygiene, injection safety, and others, and it will help hospitals prepare for our survey, as well as assess their program. For those of you who are familiar with the CMS Infection Control Worksheet, will find that the Joint Commission tool has a lot in common with the CMS document. The tool has been made available to our accredited customers via their extranet sites. We posted the tool in January, where it will remain until July, at which time it will be incorporated in the organization's survey activity guide. This slide provides the exact location of the tool on the extranet website. I would encourage you to locate it if you are accredited by the Joint Commission. And that was the brief overview of the changes made in the infection control standards for hospitals and critical access hospitals. Once again, these changes will become effective in July. And now let's turn our attention to the main focus of this webinar, the standard IC 070101. The standard is about readiness for high consequence infectious diseases or special pathogens. This new requirement primarily aims at early recognition of a patient with symptomology suggestive of a special pathogen, then handling that initial encounter in a way that minimizes transmission and protects staff and patients, and promptly activating internal and external resources for additional guidance. It spells out the 6 protocols that must be deployed. In the element of performance 1, the key deliverable is protocols. Protocols that must be readily available for use at the point of care and address the following 6 areas. First, identify procedures for screening at the points of entry to the hospital for respiratory symptoms, fever, rash, and travel history. The note clarifies the definition of the point of entry. Depending on the structure of the hospital, these may include the emergency department, urgent care, and ambulatory clinics. 2. Isolate. Procedures for transmission-based precautions. 3. Inform. Procedures for informing public health authorities and key hospital staff. Next, you need a protocol for required personal protective equipment and proper donning and doffing techniques. What also must be available is the procedure to support the provision of care while the patient is in isolation. These procedures should be based on the hierarchy of controls. And lastly, procedures for waste management and cleaning and disinfecting patient care spaces, surfaces, and equipment. The element of performance 2 requires the hospital to implement education and training and assess competencies of the staff who will implement protocols. Now let's go over the key points. The first one is the definition of high consequence infectious diseases or special pathogens. The Joint Commission has not endorsed a standard definition. We defer, and organizations also should defer to public health authorities and their definitions and resources. CDC, NETEC, state, local public health departments as examples. The Joint Commission provides a pragmatic, consensus-based expert guidance that we included in our R3 report. The key points in that guidance say that the special pathogen can be defined as an agent that is easily transmitted from person to person, has limited or no medical countermeasures, high mortality, and requires prompt identification and implementation of special infection control activities, as well as rapid notification to public health authorities. A few examples are provided in this expert-based guidance. However, keep in mind that this list can change over time and include future emerging agents. Identify protocols for screening. Where are they implemented? They are implemented at the points of entry to the hospital. The note in the element of performance clarifies that the point of entry may include the emergency department, urgent care, and ambulatory clinics. For compliance purposes, our expectation is, at a minimum, identify screening procedures must be implemented in the hospital-based emergency care areas, such as emergency department and urgent care. Procedures to support continued and safe care of the patient while the patient is in isolation. These procedures must be in place where the patient is housed. It may include the ED area where the patient presents, or the inpatient unit or area where the patient is being cared for. This requirement should not be construed as the mandate to treat a patient with special pathogen. Organizations can determine whether they can provide continued care based on their capabilities and transfer the patient. Those decisions will be made in discussion with public health authorities. To reduce exposure to staff, patients, and visitors, you must employ the hierarchy of controls. This refers to the NIOSH, or the National Institute of Occupational Safety and Health hierarchy of controls. Many of you are familiar with the hierarchy and its 5 levels: elimination, substitution, engineering controls, administrative controls, and personal protective equipment. Inform. Procedures for informing public health authorities and key hospital staff. The hospital can determine which key staff they will notify internally. Procedures for informing public health authorities should be guided by your local law and regulation. in your own internal procedures. The organization will need to refer to its internal process and policy to decide whether the organization may trigger emergency management procedures. Generally speaking, surge conditions, questions about maintaining, expanding, decreasing, or closing operations should be handled per the organization's emergency operations plan. Element of performance 2 on education and training and assessment of competencies. The what, when, and who of education and training is determined by the organization. The organization has the flexibility to define the competencies associated with the practical applications of these protocols. Just as a reminder, competency is defined as observable and measurable knowledge, skills, and abilities. Competencies apply only to the relevant personnel who will implement these protocols, and the organization can define which staff are at the highest priority of training. And this concludes my presentation. I will conclude by saying that you can always submit any questions that you may have to the Joint Commission. Our standards interpretation group will stand ready to assist you, and I would encourage you to use this resource. The Joint Commission will also be developing a resource center for infection control, where we will link to credible resources such as NETEC that the organizations can use to support compliance. Thank you for your attention.
Excellent. Thank you, Dr. Rosenberg, for your presentation. I would like to further introduce Ms. Kelly Getman. Kelly has been a nurse for 25 years and has more than 15 years of experience in the Department of Patient Safety and Quality at Denver Health Hospital Authority. She has provided education about continual readiness standards, Joint Commission preparation, and has contributed to many successful surveys during her career. Kelly, I'd like to turn it over to you to discuss the infection control standards and practical implementation strategies that organizations may consider as these are put live in July.
Great. Thank you so much. And thanks for the great introduction. We'll go ahead and get started. We can go to the next slide. And first thing I just want everyone to take is a deep breath. I think a lot of times whenever we hear new items coming from the Joint Commission or changes within chapters, we all get super anxious and nervous. But again, the Joint Commission is here to help us and just become better as we go forward with our organization. So we will go ahead and get started. So a couple of things that I just want to hit on, and I know these came in, a lot of questions are coming in, and thank you guys for putting all those in the Q&A. And then we also received a lot of questions before we started too. And the first thing, we're going to talk a little bit about these elements of performance within the new component, but just to kind of ease everybody's fears is that what the Joint Commission has done is really ease up all of the elements and really made it very user-friendly for us to be able to get through the chapter and match the languages CMS, which I think is always kind of challenging at times. So when we talk about the hospital develops and implements protocols for high consequent infectious diseases, most of the infection prevention teams that I've worked with over the years have already done all of this. And the protocols have already are there and in place. It's now just adding in the language within the new standards, within the updated standards, basically. So again, like Natalia mentioned from the Joint Commission, is we're going to identify, and this is something that we built in with COVID. I know majority of all of the hospitals have this, and the big thing too that we've noticed also is identify, and one of them is measles, right? So we identify fever, rash, whatever it may be. Within our identification, we have a lot of this information in regards to when person comes into that area. So if it's our emergency department, it's within our EPIC documentation, and we are able to identify. Isolation is something you guys have always been able to do with an infection prevention. We are really good at isolating and making sure that we are also protecting our staff in that whole. And then also informing your different agencies that need to be maybe involved. And then the infection control procedures that go in. One of the things that we talk a lot about is who is of controls. And to remember that with infection control, with any of the Joint Commission standards, is they give us a guide, but you really need to go back to your home state, your CMS regs, and all of those different pieces that fall into place that have these higher control. And then waste and cleaning, disinfection of equipment. This is something that we've, especially in infection prevention, that you have always been held accountable to. So we'll talk a little bit more about that. And then again, the education, competencies, training of staff. Whenever it changes just a little bit, we all get very nervous, but this is something that we have always had in place with competencies for staff. So what does this mean for you? What do you do? And that's kind of where I want to take some of the edge off a little bit and hopefully help you through that. This is really about, what do we do? Where do we document? How do we accomplish this for the Joint Commission and for any survey that may come into your organization via the state, CMS, OSHA, whatever may come into play. So really make sure that you're documenting your processes and your procedures, either in your EMR, your paper records, lab, emergency management processes. And then the biggest thing within those first two is to really notification process. How do you notify? Who do you notify? How does your staff know who to notify? So our infection prevention team is very strong here at Denver Health. And one of the things that they have is a bug line where you can call at any time and get information about how to escalate and what to do with that care that is happening, or if something comes within the agency that maybe we have more questions about. So very really, as infection preventionists, making sure that you guys have those avenues so that your frontline staff can know how to get to you to ask those questions. And then consider your differences in policies, guidelines, protocols, standard work, and other documentation. So policies, just as a reminder, are what you need to follow. You don't deviate from a policy. It's pretty hardwired. The one that I always share with staff that's definitely hardwired is, well, actually two. Restraints is one, and then also blood transfusion is usually pretty tight. You don't deviate from that process at all. And then guidelines, you want a recommendations. You have pretty strict things within it, but as long as the staff, if they deviate, they can document the process and what needs to be changed. Protocols are good guidance, usually algorithms. And then standard work is, where I think of always with the donning and doffing and exactly what we need to do. So really just clarifying those points of entry. We have clarified a lot of ours here at Denver Health. But, emergency room, of course, is our main entry point. But then we also have patients coming over from our ACS clinics or our outpatient clinics, and also from our urgent care. So just making sure that you are defining where those point of entries could be so that you are able to provide that education to those places. The annual plan, I know that it looks like it's been removed, but I would encourage all of you in infection prevention to keep up with your plan. You have all of these elements, even though they have consolidated, all of them are in your first plan that you've ever worked on. And this way you can just continuously keep it up. And the same with your ICRA and your risk assessment tools that you use. Keep using your tools. You'll just have to modify, and I'll show you some examples towards the end of this. Again, I reinforce that all of you are very brilliant on this call, and use your resources, use your team members, use your people within your organization to help work through these standards and talk through what is best practice for your organization. And then always, what the Joint Commission have told me many years is that as you, the biggest thing is they have recommendations, but it's really what you write in policy or in your procedure is what holds you accountable. And that's what they're going to hold us accountable as we go through any surveys. Same thing with the state, again, OSHA, any of those regulatory agencies. So a couple of things. I think a lot of people get really nervous about training and competencies. We already cover these with contact isolation. You already are doing a lot of this. But just making sure that you have some of this in writing. This is just an example of our policy and our policy at Denver Health about what's required and how we define at Denver Health, again, what our competencies relate to. One of the things, again, that Joint Commission really reinforces, it's really how you define what your competency level should be and what do you expect as an organization. So this is just a quick example of our policy, or guideline is what we call it. So if something does come up, we are able to deviate a little bit from it. And then the other thing that we work really closely is with our collaboration with our HR department and our leadership teams to support competency. Because again, as you guys know, within the Joint Commission standards, all of them connect to another component, usually within another chapter. The majority of them go into the leadership chapter. So we have a standard work for department employee files that we follow. Now, this is always a work in progress as you have maintenance to different systems where you house different things. But this is really what we have put into place. We just had a HR speak to this morning, and we always are trying to improve and get better for our leaders and our managers and all of the different people in the other departments. All right, so highlights and takeaways and tools and resources. So this I just wanted to kind of cover. This will be provided. So one of the biggest things that I just want to first, that we always get the question is, well, what do we do next? Like, how do we do this? And first off, I want you all to give yourself, celebrate yourselves now, because you have all almost 2,000 of you on this call have already taken the first steps by being part of this webinar and talk. So congrats yourself. So one of the biggest tools that I use and I've used throughout my career is this TJC infection control hierarchy. And again, this is just really addressing the fact that how do you decide what's most important and what trumps one another, basically. So what we always want to do is there's the rules and regulations, there's the CMS regs, and then there's the instructions for use, which is really important in infection prevention when you're talking about equipment and cleaning and what's compatible. Then there's evidence-based guidelines and national standards, which change. We saw this a lot during COVID. And then there's also your consensus documents, which is your plan, what you decided as an infection prevention team. And then what do you do with it? And then how do you put it all together? And this then goes back to your infection prevention team. And how do we organize as an infection prevention and control? And how do we put that into policy so that we can help support our staff? We do have the link on the bottom of this, and I know you'll all be able to review this slide. So if you have any questions about this one. And this is just to reinforce again, we went from 12 standards down to 4 standards, but really just all consolidated. So again, I really encourage you to use these resources from the Joint Commission and see where everything kind of fell into place. Even though it does say that on that ICO 10501 EP2 that we don't have to have an infection control plan, that's just a great way to document how you've accommodated and how you've come across all of these. And again, a lot of the elements that you met in your plan are still part of the standards. So I would encourage you to really review your plan and keep it as a great tracking tool for your infection prevention team and what you have moving forward. And then just again, a reminder that this is really a great thing that the Joint Commission has done for us is they've really clarified a lot of the redundancy within that infection control chapter. So it's makes things a lot easier to understand and just more consolidated. My favorite part is the fact that it now matches the language with CMS more closely because that seems to be where staff have a hard time differentiating when we do have a CMS visit or we do have someone from Medicare, Medicaid, and how do we define those different elements? And this is just some of the stuff that we do at Denver Health to help our staff, not only with competencies, but to get them ready for survey. I know that some of those questions came up within the Q&A. So we have built many tracers. The example I have up here is on C. diff, but this is where your teams could build, and which we will be building one on how to don and doff, or how do we talk about what is our definition, or what did we decide as an organization what our definition is for high consequence infection disease or special pathogens. And this is where you can build these mini tracers. And what we've done at Denver Health is we have the question, we have all of the answers listed. So when one of our staff members is talking to a surveyor, they're not caught off guard. They can speak the language, they understand. And we've also built these so that any staff could use them. It's just why we have the question answer. And then they're able to do these to get like ProCap points or more competencies within our organization. And then the other one that we have is something that we also like to just keep track of. And this is how we keep track of what our standard is, our elements of performance. And then we go back and we, excuse me, we go back and we review ourselves to make sure that we're meeting or where maybe the information is located. So you can see on this one, we still have some of our information within our annual plan. And again, it just gives us the information to where we know we're being compliant with the evidence with the EP. So I just wanted to reinforce again where you find things on the Joint Commission. All of these are when you are part of the Joint Commission, you're able to ask SIGs. The question I get all the time, well, if I ask a SIG, would my SIG then be brought up when they come and survey? They will not. It's totally two different departments at the Joint Commission. Any question you ask the SIG is probably a question that 100 of us have. So please keep your questions going to the Joint Commission and asking them, because that is actually how they are able to clarify. And then they also go back and train their surveyors to make sure that they're meeting the elements or meeting those questions that people are asking. But it will not follow you back to survey. And then there's always more standards online, the FAQs, so many resources within the Joint Commission site. Just buzz around and it's look for it. You can't break the site. And there's just a lot of information. The Joint Commission is here for us. We are their customers. So something to also always remember. I know it's super stressful when they come in. But they actually are doing the best for our patient population and our staff. So again, what to do next? I just am reinforced with you that you guys have already taken the first step by being here, by asking the questions. Use your resources, make friends, ask questions. Don't, anyone on this call or different organizations within your states, your departments, connect with your patient safety quality teams and your IPs team, collaborate, network. Again, you guys just being here have already made the first step. And then everyone is responding. So you're not alone. None of us are alone as we review these. So collaborate with other institutes for their resources, tools, and then reach out to NETEC and RESP as needed to. They'll always help out. So just a reminder again that we're moving from down within our EPs from 51 elements of performance to 14 EPs, which does make it more doable. I will say that within those 14 EPs, there is some combination of different things, but that all is what happens when we reevaluate and relook at things. And the same content is within the EPs, is to make sure that, one of the things is that it is the same content, but all they've done is clarified and combined to streamline. So you have all the information, and you guys will do great in your next surveys. The Joint Commission. So where do you go? What do you do? How do you get the information? The Joint Commission has alerts. You have connection. You have their R3 report. You also get Sentinel event. One of the questions we are getting is, well, how do we know? How do we do this? Well, you got to get your name on these listservs. Join the Joint Commission alerts. They're amazing. And then there's also Patent Healthcare Consulting, a monthly newsletter, news from the Joint Commission and CMS. It's a great one to also just get. It'll come to your inbox. But there are many, many more newsletters, reports, listservs, just depending on if you're with the Joint Commission or one of the other regulatory agencies. And this is just a list of all of our information that you will be able to, the resources that will be available at the end. All right, question and answers. Thanks, you guys.
Thank you, Kelly. That was a great presentation and really appreciated the more detailed explanation you gave for how organizations can begin to approach implementing strategies for these Joint Commission requirements. I would like to reintroduce Ms. Caroline Pearson, who will moderate our question and answer session. Carolyn is the Program Director for Mountain Plains Regional Disaster Health Response System and the Biocontainment Unit at Denver Health. Her work focuses on healthcare emergency management, coordination and collaboration, and capacity building efforts to enhance healthcare preparedness and response efforts. Carolyn, I'll turn it over to you to help take us through some of the questions.
Awesome. Thanks, Angie. And Thanks, Dr. Rosenberg and Kelly, for that wonderful overview and discussion of the revised infection control Joint Commission requirements. I'm very excited to be here today and have the opportunity to moderate questions with our esteemed group of panelists. We've collated the questions that were submitted during registration to guide the Q&A session, and we'll also work to respond to questions in the chat as time allows. All right, so we're going to go ahead and get started, and we're going to start with some of the Joint Commission specific questions, both from the questions that were submitted during registration, and then I'm seeing that some of the questions in the Q&A are also asking similar questions. So Dr. Rosenberg, I'd love to start with you. When do the standards go into effect? And secondly, what are the expectations for a Joint Commission accredited facilities with these standards?
The standards go into effect in July of this year for hospitals and critical access hospitals. These changes do not affect yet our non-hospital programs, but a similar rewrite initiatives are being undertaken in non-hospital programs as well. Regarding the expectations, I would say turn to the assessment tool that we showcased today and that Kelly also spoke about. It really will spell out a lot of the concrete information for you and hopefully allay some of the anxiety. I think that you will find it pretty straightforward, and it really does present the universe of possibilities that you can encounter on the survey.
Dr. Rosenberg, that's really helpful. There was a lot of questions about applications to primary care settings, outpatient settings, et cetera. So appreciate the awareness of standards being revised for some of those non-hospital or non-critical access hospital partners. As a follow-up, would love to learn where the Joint Commission standards came from, where these updated Joint Commission standards came from, and who was involved in the process.
Now, when we revise our standards or create new standards, the information comes from a variety of sources. First and foremost, probably the hierarchy that Kelly talked about informs a lot of the work that we do. Law and regulation, conditions of participation, that was a kind of centerpiece in this. We purposefully aligned to the conditions of participation more closely because it is a requirement for the majority of hospitals, and it does not make sense to have linguistically different requirements for the same thing. We talk to experts. We call them technical advisory panels. For the infection control project, there was no need to convene a panel for the chapter, per se. A lot of things that got revised are established, their established standard of practice. But we did have a separate panel of experts on emerging special pathogens. It contained, I think it included 8 experts from a variety of organizations, including representatives from NETEC and SPAR and other institutions, CDC. The names of those experts are listed on our R3 report, and their guidance really did inform the content of the new standard IC 07011 on special pathogens. I would like to add also that because many of the surveys that the Joint Commission does, we do on behalf of CMS, we have their deeming authority. Whenever we revise standards, and that was the case with infection control requirements, they go to CMS for their review and approval.
Thanks, Dr. Rosenberg. And another follow-up question for what you just shared. There's a lot of questions in the chat, and we received a lot of questions in advance of the registration, in advance of the webinar, during the registration. What has changed with the revised standards, and is the IC plan still required?
IC plan. Well, Kelly mentioned this, and I will repeat. The requirements for the IC plan were eliminated. However, organizations can still use the infection control plan. It can be your centralized location for documenting all the things that you're doing in your programs. It's just in the survey, we will not be asking you to produce a plan on day one. So keep in mind that the requirements for documentation are still there, right? This is your risk assessment. This is your requirements for policies and procedures. You will need to also produce the 6 protocols that we discussed for special pathogens. They don't need to be 6 different protocols. You can package them any way you like, but those are also written documentation requirements there. Training competencies, they must be documented and they will be reviewed by the Joint Commission. So infection control plan is still an option for you. Please use it.
Very helpful. So it sounds like although it's no longer required, it's definitely a recommendation to collate all of the documents and processes and policies that might be leveraged for your infection prevention team across the institution.
If that's what you want. But the Joint Commission surveyor will not ask you on day one of the survey to produce it.
Wonderful. Thank you. The next questions that I would love to talk about are education and competency. In general, and Dr. Rosenberg, I'm going to start with you again, and then would love to hear from Kelly and Angie as well. Dr. Rosenberg, what are the education and competency expectations with the revised standards?
A lot of flexibility in that requirement. If we're talking about the requirement 07 or 101 on special pathogen, a lot of flexibility there. We understand that it could be a heavy lift for some organizations. Training, competency, it's time consuming. We quite understand that. You can prioritize training. You can define the key personnel who will need to get this training. So the scope of this is entirely up to you. We do want to see some initial effort with this. So I would say the organization decides. I've underlined the important part about competency. So competency needs to have that demonstration assessment of competency component, but it can be achieved in a variety of ways. I know that some organizations have focused competencies on personal protective equipment, the donning and doffing, and that in itself is huge if we're able to train people up to do this properly. So, very, very flexible approach. And for the remainder of the chapter, as always, competencies, education, and training, those are defined by organization. There are some exceptions. OSHA regulations, as you know, has some required training that needs to happen for the employees. So do follow that hierarchy. But competencies, what you define as competency, what is important to you as an organization to be able to see your staff member perform something competently, we will defer to you and to your policy.
Thanks, Dr. Rosenberg. Kelly, would love to hear a little bit about how the organization Denver Health would respond to the education and competency expectations.
It's exactly like what Dr. Rosenberg just mentioned, was the fact that we define where we're at and what we're doing with different departments or different areas. So I think with the infection prevention side, we have really prioritized training and really wrote into like who is like your first line and what do they need to know. So your competencies with somebody coming into the emergency department around infection prevention may be really in regards to recognition and then isolation and then, handoff and then notification. So that may be where your competencies fall into play. And then once we know what we're dealing with, then that may be where your donning, doffing, and your specialized team comes into play, or your isolation, airborne, whatever it may be. And this is, I think, this is why I really encourage everyone on this call to really reach out to their safety quality team Because again, we do competencies not just around infection prevention. We have competencies in regards to restraints, and there are very specific CMS regs that we have to have and be compliant in, and that we have to show that people know how to tie, that they actually can do it in person and understand it. And so something to remember that this is not the first time that we've had to have competencies. So really push heavy onto your organization to see where they want to go and what they want to do with their competencies.
Great. Thanks, Kelly. Angie, would love to hear a little bit more about what NETEC has to offer for competencies, particularly around training and education.
Yeah, thanks, Carolyn. I think there's a couple things that I would add, and I wholeheartedly agree with everything that Kelly and Natalia mentioned. I think the thing that I would add is that NETEC does have a lot of training resources available in our repository. So skills checklists, training guides, thinking about how you can start with the minimum expectations, and then if you want to advance preparedness, what might you layer in? I would also add that for the different levels of the system of care, that actually at the highest level, the regional treatment centers are already conducting quarterly training with their teams, which includes skills practice, identify, isolate, inform, PPE donning and doffing, as well as other critical skills such as laboratory specimen collection and waste packaging. So they can serve as a resource for you in your region. So I'd encourage you not just to reach out to NETEC, but to contact your regional emerging special pathogens treatment center. And then for our level 2 and level 3 facilities, as the NSPS is further established and expanded, we are asking for higher levels of training for those staff who would be providing direct patient care, with at least twice annual donning and doffing of PPE for special pathogen response team members, and then at least annually on skills for individuals within the emergency department, and having refresher training that's ready to go at the time of activation, so that if it has been 10 or 11 months, you have a just-in-time aid, which you can also access via NETEC or your regional emerging special pathogen treatment center.
Wonderful. Thanks, Angie, Dr. Rosenberg, and Kelly. I recognize we have about 4 minutes remaining on this webinar session, but want to acknowledge that there are some questions that we were unable to get to, and we'll follow up at a later date to make sure that we get questions and answers to those questions. All right. So as we close out our event today, I just wanted to announce, and I know NETEC is excited to announce, a new resource repository that was posted on the NETEC website, and Jason has been posting in the chat as well. And to announce that NETEC will also be offering a series of webinars diving deeper into the specifics for the revised joint standards, helping to provide resources, support, and services. And as a friendly reminder as well, NETEC offers support and services for special pathogen preparedness, and you can submit a technical support service request at netec.org or email info@netec.org. Additionally, please feel free to submit a request online to start the Special Pathogen Operational Readiness Site Assessment, or also known as SPORSA survey, and contact us at any time for questions, support, and services. Angie shared a little bit about that NSPS tiered system, and if you're curious in learning more, this would be a great way to learn more. Additionally, NETEC does offer resources, next slide please, that are available to healthcare professionals, frontline and assessment facilities, EMS agencies, and anyone who might encounter a special pathogen in their work. If you have questions, again, about resources and what is available, 2 ways to access: via that email, info@netec.org, or by submitting a technical assistance request at netec.org. And we'd also love to stay in touch. As I mentioned, there'll be additional webinars offered in the coming months. Please connect with NETEC by following us on social media. You'll see all the different ways that you can learn about NETEC, including Twitter, Instagram, LinkedIn, and the different websites and access points for getting in touch with experts. Awesome. And that's all for today, folks. This brings us to the end of today's webinar. I just really want to extend a big thank you to Kelly Getman and Dr. Natalia Rosenberg for joining the webinar today on the revised infection control Joint Commission standards that will go into effect July 1st, 2024. And thank you again to all the webinar attendees for dedicating an hour of your time today. We sincerely appreciate your questions, your participation. Hope you have a wonderful Friday. Goodbye.